Welcome to Your Health Matters with Dr. Benjamin Bryant. Today I'm filling in for Pat Williams. Pat has company from out of town, I understand.
He does.
And how are you today, Doctor?
Oh boy, well, it's cooling off a little bit, so I feel a lot better.
Finally got a break.
I know a lot of people out there who were really impressed by how hot it's been this summer.
Yeah, it was pretty miserable.
Wow.
I want to take a second and thank you for coming out to Discovery Day.
It looked like you had a very nice program out
Yeah,
there.
thank you. It was nice to see you. It was, appreciate your support.
Absolutely. It's a great sort of thing that happens in our community. Guys like Matthew take that on and do something that really provides a service for the whole town. So.
Did you see the peanut butter cones?
Yeah.
Yeah, that was good. That was, Dr. Bryant donated the tongue depressors to spread the peanut butter, so kids didn't have a sharp knife to, get cut on, and it worked out well. Kids had a lot of fun making their bird feeders.
Oh, that's great.
So it was a lot of fun.
That's great.
So today we got question and answers, part 2.
Part 2, a couple, not last session, but the session before, Pat had received quite a number of questions from you folks out there to have us take care of here on the show, and we got through a lot of them, but we still have some to go.
Good.
So, and we take this very seriously. If you folks ask questions, we want to make sure that we answer them the best that we can, okay? So this question came up, Matt.
Yes.
Why are chicken and fish promoted for good health over red meat? What is in the beef that is dangerous?
Good question.
It is a good question because we hear that all the time, the Mediterranean diet, and not eating so much red meat. Some people take it to mean you shouldn't have any at all. There is actually some science in there, but it's not as severe an issue as maybe it's made out to be. Okay. When we're talking about red meat, we're talking basically about beef, pork, and lamb.
Okay.
Beef, pork, and lamb. And they have more cholesterol than chicken and fish and turkey and that sort of thing. The red meats do contain more cholesterol. They also contain more what's called saturated fat. And saturated fat is the fat that can raise blood cholesterol, make heart disease worse, make peripheral vascular disease, like when people have narrowing of the arteries that go to the brain, the carotid arteries, that predisposes you to a stroke. People can get narrowing of the arteries in the legs, which makes it so you have pain when you walk, that kind of thing. And if the meat that you're eating has more cholesterol and saturated fat, it can make those problems worse. So that's one reason. Chicken and fish have less saturated fat. In some fish, particularly oily fishes like salmon, there's what are called the omega-3s, which are protective. They're the good fat. They're the kind of fat that when people take fish oil, for example, that's what they're doing, is they're getting those kind of fats. The data is not real clear on that. There is some evidence to suggest that it can help with peripheral disease, not with the heart so much, but it's certainly not harmful, like the other fats can be harmful. But there should be a kind of a balanced perspective on this. There are lots and lots and lots of people out there who enjoy red meat, have a nice burger on the grill, nice T-bone on the grill, okay, and their cholesterol's in the normal range. So it's not straight cause and effect. And this is what I really want people to understand, is that it's not straight cause and effect. Meaning, you eat red meat, you're definitely going to have elevated cholesterol. That's not the way it works. It's a very complicated issue in terms of people's metabolism, but if you look at statistics, which is what we have to do to get, okay, here's a big group of people who does one thing, here's a big group of people who does a different thing. Do we see any differences in those populations? Yeah, we do. We see slightly increased risks of too much cholesterol, heart disease, strokes, that kind of thing. But if you pick an individual person out of there, it may not apply to them. This is just averages. So the idea that you cannot have a burger or that you cannot have a steak, that's not correct. That's just simply not correct. Like everything else, these things are better in moderation, once or twice a week, like that, and then get different sources of protein on the other days. There is some evidence to suggest that you're better off if you're not having red meat every single day. Okay, but it is important to have that balance of perspective.
Are some people, I was under the impression for stroke and heart disease that you may be predisposed to that? Or is that just
You mean genetically?
Yeah.
Absolutely. As a matter of fact, that's the most important risk factor, the most important determinant.
Okay. So,
Okay. Yeah, there's genetics, your family history, you know, and then there's your lifestyle and your diet and so on. And genetics plays even a stronger role than the other.
Oh, okay.
It really does.
Okay.
And that's why, you know, when you go to your doctor, they ask about your family history because they take that into consideration.
Right.
You know, we're going to just wander off just for a second here. If your cholesterol is too high, I mean, you're going in, you're seeing your doc, and you're getting your blood drawn every year, sometimes more often depending on the circumstances, but at least every year, to monitor, and you find that your cholesterol is too high, or that your bad cholesterol, your LDL, is too high. Okay, that is something to take seriously. You know, and diet and exercise, they're always advocated, and rightly so. But if that isn't enough to control it, then there are medications that do a very good job of lowering the cholesterol. They have side effects that affect a certain number of people, but most people not. And it's definitely worth it to take those medications to keep your cholesterol in a safe range. There's no question about that. So that's just another little piece of the puzzle here. People can think, well, you know, I mean, if I'm on a cholesterol lowering medication, I can have as many steaks as I want. Well, it doesn't quite work that way either. You know, it's just you know, reasonable. It's common sense, moderation. Okay, good balanced diet. Eat healthy, good balanced diet. There's tons of fun stuff you can eat in there. All right, moderation in the red meat. Monitor your cholesterol. If your cholesterol's too high, treat it. Simple. Easy. Okay?
And the hospital has dietitians too.
That's right. Well, we had Sean Cooper on the show last spring.
Right.
I've recently received communication from Sean about some of the work that he's doing, and it's tremendous, the success that his patients are having with him. Right. In terms of weight loss, in terms of getting their numbers better, in terms of empowerment and how they feel about things. I mean, it's really pretty impressive. Right. And he is available through the hospital. That's right. Thank you.
That's a good point to make.
Oh, thank you for bringing that up. That's really important. Sean is doing great work.
Yeah. Good.
Well, we have another question.
Yeah. What else we got coming up?
Well, here's a question. Why were baby deliveries stopped in Conneaut? Why were baby deliveries?
That happened since I moved up there. That hasn't been. That's just been in the last 15 years or so.
Yeah.
Yeah.
Well, basically, here's what happened. The regulations that govern the certification of neonatal care and pediatric care. See, all of this stuff is overseen by the government.
Absolutely.
And there are certain requirements that you have to fulfill to get certified to do that kind of care, and those change. They change. They change all the time, and strangely enough, you never see it so that there's less regulations. There's always more for some reason.
Yeah.
It's kind of like that all over life.
Yeah.
But the regulations increased, they changed, and in order to comply with those regulations, it imposed costs on the hospital that were not sustainable. In other words, the government made it so that it cost too much. That's why it was stopped in Conneaut.
Yeah.
That's the simple answer.
Right. Yeah. That's
A lot of people were sorry to see that go. It was a hit to the hospital. But on the other hand, these things have to be done properly, and that was just outside the scope of our ability to pay for it.
Now, does the hospital still have OB/GYN care, or?
OB/GYN care is definitely available through UH. Dr. Ahuja, Sam Ahuja, is with UH. A lot of people out there know him, really like him. He's a great doc. He's taking care of my family. He sees patients in Ashtabula. He operates primarily in Geneva. I think he may go to Geauga, but he's primarily in Geneva. And he sees our patients. I know that the hospital is very actively involved in recruiting another GYN for us. We'll probably be based in Ashtabula, but we'll see patients and operate here in Conneaut. So I know that there's a strong push for that.
Good.
Okay, so that's always going to be available.
Because that's, now, I've never had a baby, but those are the doctors that deliver the babies?
Right, it's called OB, which is obstetrics, which is baby delivery, and GYN, which is gynecologic surgery and that kind of thing. And they're two different things.
Okay.
Some people who trade in that specialty concentrate on deliveries. Should we just wait?
Yeah.
Just wait. That's a mistake by the hospital operator. So we'll start.
Yeah.
So we'll start again now.
Yeah.
Okay. Some OB/GYNs concentrate on deliveries. Some don't do any deliveries and just do gynecologic surgery. Some do both. Here, for the purposes of our hospital, it would just be the gynecologic surgery.
Yeah. Very good.
My husband snores heavily. Should he be checked out for sleep apnea? Simple answer to that, yes, absolutely, absolutely. Sleep apnea, what is it? Well, what happens is when you fall asleep, a lot of muscles relax. A lot of muscles, when you're awake, they're not relaxed just by virtue of being awake. But when you fall asleep, a lot of that sensory is withdrawn and the motor to the muscles is withdrawn and the muscles relax. And what happens is that the shape and configuration of the upper part of the airway, the mouth, the throat, and so on, change because of that relaxation. And things can kind of slide. And what they do is they slide and they occlude the windpipe. So people who have sleep apnea, when they fall asleep and that happens, they stop breathing. And after a while, the gases build up in the blood and so on, and they wake up. And they may not wake up to the point that they realize they're awake. It just jolts them enough so that things change and they start oxygenating again and so on. Well, that goes on and on and on, over and over and over. And these people who have sleep apnea never feel rested. And how could they?
Right.
Because their sleep, their deep sleep particularly, is being disturbed all the time. It's being disturbed all the time. So they're tired. These are people who can fall asleep driving. They really have trouble during the day having any energy. It's terrible.
Right.
And so anyone who has that level of fatigue absolutely should be checked for sleep apnea. Anyone who snores should be checked for sleep apnea. How common is it? Extremely common. I mean, if you are walking down the sidewalk, okay, pretty much 1 out of every 3 people you see will have sleep apnea. That's how common it is. Now, why should it be taken seriously? Well, just the sleep aspect alone and the quality of life aspect alone. But there's a lot more to it than that. When that happens, when the sleep apnea happens, it puts a real strain on the system, as you might imagine, and it increases the risk of a lot of other things. For example, high blood pressure. Anyone who has a tendency to high blood pressure, if they have sleep apnea, it's going to make it much, much worse. This is just how it works. When the sleep apnea happens, a lot of chemicals get released into the bloodstream, hormones get released into the bloodstream, which cause the blood pressure to go up. And if you have a predisposition to high blood pressure and those chemicals get released, and that blood pressure goes up, it goes way up. Okay? We've talked about blood pressure on this show many times. Its relationship to kidney disease, Dr. Menon talked about that last time. Heart attacks, strokes, on and on. Eye damage, I mean, so the high blood pressure factor is definitely part of it. We talked about the stroke part of it. It's very hard on the heart. And that's probably the worst thing. That's probably the worst thing about sleep apnea, is that it's very rough on the heart to have that happen. Okay, it can cause the heart rhythm to go off, which is dangerous. It can cause heart attacks. That can actually cause a heart attack. Sleep apnea can actually, on its own, cause a heart attack.
Oh,
Okay? Heart failure. Okay? People with sleep apnea frequently are plagued by headaches. You know, their head hurts. It's a dull, achy, kind of foggy hurt. And it happens frequently. And people who are treated successfully for sleep apnea, which we'll talk about in a second, wow, you know, my headaches are gone. I used to have these terrible headaches, and now I don't have them anymore. That's just one of the benefits. So headaches, depression. If your sleep cycle is interrupted constantly, you're not getting enough sleep. It's not just that you're going to be tired. You're going to be depressed. I mean, it really takes a lot of the fun out of everything. So there's that. It can, you know, the attention deficit disorders makes them worse. So it's hard to concentrate on things, or hard to concentrate on things for any prolonged period of time. So it's just really, I hope you're getting the idea that sleep apnea is significant. It can have a significant impact on your quality of life and on your health. So it's something that if you have any of the kinds of sorts of things that we're talking about, or you know somebody who does, the kind thing to do is to get checked for sleep apnea. Now, how do you do that? Well, you go to your doc, or you can call a hospital, and there's a test for it. And UH has a really nice testing facility at the Lodge in Geneva. Nice place.
right.
All right. And what you do is you go there and you spend the night. And they have special ways of monitoring, and which are painless. You know, they don't bother you. And when that test is over, you know whether you have sleep apnea or not. You know whether you have it or not. It's conclusive. All right. So if you're diagnosed with that, by far the most common treatment for it is one of these CPAP machines or BiPAP machines. And they take a little getting used to. There's no question they take a little getting used to. But millions of people do get used to it. I mean, it's second nature to them. They just put it on. Okay? And because the way that it works, it doesn't let the airway get occluded. So the sleep apnea stops. Now, once people are being treated and they get used to the CPAP, and the sleep apnea stops. Folks, what you should do is you should talk to one of those people. Seriously, you should talk to one of those people. Somebody who's been diagnosed with sleep apnea, who's been treated, who's on their CPAP or BiPAP, and who now doesn't have sleep apnea anymore. You should talk to them and ask them, what difference has it made in your life? Okay?
Huge.
That will make this point that I'm trying to make better than anything I could ever do.
Right.
It's just to talk to somebody like that. They can't believe it. It's like they say, I got my life back.
Yeah. I was diagnosed with sleep apnea, and I was on the CPAP, and it took a little less than a week to get used to it, but you got used to it really quickly. And then I had the gastric bypass surgery. I lost over 100 pounds, and I lost my sleep apnea. I mean, I'm sleeping, I don't even use the CPAP any longer, you know, because I lost all that weight. Huge difference.
Folks, there it is. Okay, yeah. There it is, and Matthew just illustrated the relationship between being, you know, significantly overweight, because, you know, fat collects in those tissues up in the airway too. All right, and when those shrink down, it can be, not always, but in Matthew's case and in a lot of cases, you don't need your CPAP anymore.
Right.
So, but when you were successfully treated for sleep apnea,
over 2 years,
did it make a difference?
Oh, it made a huge difference.
Yeah.
The quality, not napping during the afternoons, you know, just being able to stay awake, more alert. You know, I was able to drive, you know, on day trips, you know, without falling asleep, getting tired.
Fantastic.
You know, would go on day trips, and I would literally pull into roadside rest and take a nap because I couldn't go on any further.
Sure.
You know, just
sure.
You could feel yourself getting dangerous. You know.
Sure.
And yeah, huge difference. The CPAP made my life. But then it was a couple years after that is when I had the surgery and lost my weight. And
a lot of good things happened then.
Right.
Well,
yeah.
you can't. I mean, you can talk about statistics, and then you can talk to a real person.
Right.
It's
right.
a whole different proposition.
Right.
All right. Okay. And if you have any other questions about this or about you know, anything we've talked about or anything else, you know, you can contact Pat. You can email Pat, or you can call. It's probably floating at the bottom of the thing.
Yeah.
Call my office and just tell Karen, I got a question that I want Doc to answer on the air, and then just tell her the question and we'll do it.
Right.
We'll cover it.
Now, I had the one question we talked about the last time, and we didn't get it covered on air. Can I bring that up again?
Of course.
Okay. What was brought up to me numerous times was doctors order all this testing because you guys receive extra money in your salary for ordering the testing, like a MRI of the brain or blood work or x-rays, you know, whatever the case may be, because doctors get, and it's a dirty word, a kickback for ordering those extra tests. Can you straighten us out on that?
First of all, see, no question is out of bounds.
Okay.
People think about this stuff. They wonder about this stuff, and it should be out under the sunlight.
Okay.
For everybody to see it. All right. Most doctors, the answer to that is just quite simply no.
Okay.
They do not participate in that kind of thing financially. Within UH, no. It doesn't work that way. The number of tests that the doctor orders, big number, small number, does not affect their compensation. And that's very important because they have no financial incentive to over-test.
Right.
That's very important.
Right.
Now, there are some places where the doctors own the equipment, Like some doctors will have, or a group of doctors together will have radiology. They're not going to be able to afford an MRI, I can tell you that, or a CT scanner, or a lot of stuff. But they may be able, for example, to do bone densities, which is just an X-ray. Okay? And now, under those circumstances, if they own the equipment, and that's perfectly legal to do, all right, they will get part of that if they own it.
Right.
That's not the way it is in UH. No doctor owns any of it in UH.
Right.
And the trend, quite honestly, is more and more is for doctors to be part of big groups where that's the case. And the reason for that is because the regulations that have come down regarding the electronic medical record. If you're going to see Medicare patients, if you're going to see Medicaid patients, all right, then you have to have an electronic medical record. And quite honestly, whether you're going to see those patients or not, if you're going to practice in this day and age, you have to have electronic medical record. Okay, those are prohibitively expensive, except for very big organizations. I mean, they're just hundreds of millions of dollars. They're just tremendously expensive. I mean, for an individual physician to get a medical record doesn't cost that much, but it's still very expensive, and it's a financial burden that most private practices can't carry. So there's a huge economic incentive for doctors to get into bigger groups like that. Okay. And in those bigger groups, no, you don't get any financial benefit from the lab, from the X-rays, anything. Now, I am going to bring this up. This is touchy, and I may get in trouble with some of my colleagues. Okay, but I don't care, because to me, you have to put the patient first. You just have to put the patient first. If you don't, you got no business doing this, in my view. All right. There are procedures that doctors do that they bill for, and that's what they do. Okay. Now, if you think about it for a second, you might say, well, wait a minute. You know, there's a conflict of interest there. Conflict of interest. Well, what do you mean? Patient comes in and the doctor recommends a procedure, for example, like a colonoscopy. Let's just say a colonoscopy, which I do that procedure. Okay. The colonoscopy gets scheduled based on the doctor's recommendation to the patient. The patient can always refuse it, but most times they won't, because they know the doctor is looking out for their health, and they wouldn't do a procedure like that unless they had a very specific reason for doing it. That is one interest, the patient's interest, the patient's well-being, doing what is appropriate for the patient. Then there's the doctor's financial interest. The doctor, the more of these procedures he does, the more money he's going to make. The doctor's financial interest. Sometimes they can be in conflict. I have seen it. I'm going to tell you, I've seen it. I once had a patient, a young woman. I think when I met her, she was 38, 39. And she had had a colonoscopy every year for the previous 7 years. So I thought, whoa, there's got to be something really unique about this case. So I went back and I pulled all the records. I pulled all the office notes. I pulled all the op notes. I pulled all the path reports. This patient was walking around thinking that she had a diagnosis of ulcerative colitis. It said it in the note, ulcerative colitis, and this was the reason for doing the procedure and so on. Well, when I looked at the path reports, did not support a diagnosis of ulcerative colitis. Didn't. And in terms of symptoms and so on, she really wasn't having any symptoms. This was an unusual case, but it was a case where, you know, I wasn't there, I didn't have the discussions, I didn't see her that time, I don't know. All I have is the evidence based on the path reports and so on. And based on my review, it looked to me like most of those colonoscopies were not indicated. She didn't have to have them because there was nothing going on. Instead of having them every year, she could have had them. She could have had one, and then she could have had one 3 years later, and then based on that, 5 years later. You know, if it was normal, could have done that. That's not what happened. Now, I don't know how common this is. I don't know how rare it is. Okay? I'm just saying that the potential is there for a conflict of interest. And what does this mean? Folks, what does this mean to you out there? Well, what this means is that if you're going to a doctor who recommends a procedure, you make sure that you ask them, why am I getting this? What are we looking for? What is the reason why we're doing this? Okay? And then you need to have an answer in terms you can understand that makes sense to you, where you say, oh, okay, I get that. Yeah, that makes sense. I'm going to be safer, you know, like that. It has to be like that. And beyond that, if you still have an uncomfortable feeling about it, if you still have an uncomfortable feeling about it, you can get a second opinion. Absolutely get a second opinion. What that means is, on your own, you just call up, you know, you ask around, you ask your doctor, you ask somebody else, ask at the hospital, ask the staff at the hospital, who else is there who might do this procedure, and then go and see that doctor and find out if they think that this is legit, if they would do the same thing, if they think, yeah, you know, the evidence says this is what we got to do. It's got to be based on the evidence. Okay? And if you get two opinions where they concur, then you can feel pretty safe, okay, that this is the right thing to do. I'm just saying that you should be aware that there is the potential for this conflict of interest. You should make sure that things are explained to you clearly, simply, in a way that you can understand it, and it has to make sense to you. And if it doesn't, you can get another opinion. And then after that, you can just say, no, I ain't doing it. So you. Now, on the other hand, there's a lot of crazy thinking out there in the public. You know, doctors are just trying to rip us off. They don't really know what they're doing. All this anti stuff. You know, and so that I can go on the internet. I can figure this out. Oh, that is dangerous as can be. Okay, you know, you cannot take what I have just said and use that to justify in your own mind avoiding getting care that's going to be crucial to your well-being. That's just not a very smart thing to do. You know, bottom line, you got to have a doctor that you like and that you can trust. Somebody who listens to you, somebody who explains things to you, and somebody where you think, okay, A, this person knows what he's doing, B, this person is looking out for me. That's what you got to have.
I know, you were my doctor, and what impressed me about you was just like we're sitting here talking right now, we could be in your office, and you sit down and you have the same demeanor, the same empowerment for the patient, you know. You're just really thorough, you know, and you're easy to get along with and easy to talk to.
Well, you're very kind, Matthew. I mean, it's just basic human decency, you know.
Yeah, but there's some doctors that just rush in and rush out. They don't want to, you know, they don't want to take the time. Yeah. They don't, you know.
Well, you know, there's a lot of pressure on docs. Now, listen to what I'm going to say. There's a lot of pressure you know, the sort of the cartoon, if you will, is the doctor in the office with the patient and the practice administrator standing outside the door with a stopwatch.
Yeah.
You know, well, you have to see a patient every 7 minutes, and it's like that. In a lot of places, it's like that. And that's terrible. As far as I'm concerned, that completely debases medicine.
Right.
Okay, then you can't call it a profession anymore.
Yeah.
You know, it's like producing pork bellies. I mean, come on. All right? But even within the constraints that are imposed by modern economics on medicine, even within that, the doctor can still connect with the patient.
Right.
If they understand how important that is, if they have the personality to do that, if they have the willingness to do that, which they should in my view, the doctor can still connect with the patient, and even a fairly short amount of time, the patient realizes, okay, he heard what's on my mind, or she heard what's on my mind, and she is listening to me, and she's responding to me. I can tell she knows what I'm concerned about, and she's giving me good information. See, you can do that in a fairly short amount of time.
Yeah.
Yeah, you have to do that.
And I like it when the doctors, like I see 2 or 3 different doctors, you know, for bipolar, heart, and, you know, but they feel like a team, you know. One doctor I know emails or sends faxes over to another group of doctors, and they respond back to them, and it feels like a team approach to my health, you know.
That's a very good point.
Which is huge.
Oh gosh, it's huge. Well, you know, and I do mention that I mentioned this before. That really is the power of our electronic medical record.
Yeah.
That really is. I mean, you know, I'll see a patient who comes over from a doc who's within the UH system. And when I pull your record up, everything that has been done, for example, you went and you saw Dr. Kumar, all right? Well, I pull up your medical record, I see Dr. Kumar's note. I see exactly what he's thinking. I see what he told you. I see what testing he's already done. I can see those tests. I see all the results. I see everything right in there.
Right.
And so
We're not duplicating efforts.
We're not duplicating efforts. We're not letting things fall through the cracks.
Right.
It really is. It's a safety issue.
Right.
So that, you know, and that helps, I think, with that team approach that you're.
Exactly. Right. Exactly.
Well, I kind of got up on my soapbox a little bit here. I apologize for that.
No, I brought it up.
But
you
these
said
are
nothing's
important.
out of bounds. Yeah.
Yeah, nothing is out of bounds. These things are important. People are thinking this stuff. Much better to just hit it head on, drag it out into the sunlight, and let everybody see what's going on. Much better.
Right.
All right.
Well, I appreciate that.
Okay. Well, we got one more question we're going to do here, Matthew.
All right.
This is also kind of a touchy one.
Okay.
Here's a question just the way it came in. When doctors diagnose a grave situation with a patient, is it customary that they tell the patient the bad news, or do they sugarcoat the issue? That is a very important question. The short answer, in my view, I mean, I have to take a step back. You're not going to get a uniform approach to this among all different doctors. They're not, because people are people. All right, just like every patient is different, every doctor is different. Everyone has their own personality. Everyone has the things they're comfortable with, and that they're not comfortable with, and so on. Having said that, in my view, the doctor has the obligation, and I'll use that term, obligation, to tell patients the truth, period. Now there's ways and ways of doing that, of course, but what you hope for is that the doctor has the kind of relationship with you where he can sit down with you and talk straight across and everybody feels comfortable. And then difficult issues, sensitive issues can be presented in a way that's safe and in a way where everybody feels safe, where everybody feels like, okay, this is a serious conversation, everybody here is on the same page, everybody here is on the same team, everybody here wants the same thing. What we need is good, clear, high quality information. Everybody's a grown-up. I mean, everybody's a grown-up, okay? Everybody's in charge of their own head, everybody's in charge of their own life, okay? And people need to know what's going on so that they can live their life the way and make the decisions that they feel comfortable making, that make sense to them. They need the information. And it's the doctor, in my view, it's the doctor's obligation to provide that information. Now, sometimes in these kind of situations, they're fluid. Things change. Might not have all the information that you need to be sure. Okay? Well, we see this and this is what it looks like, but we don't know, etc. Okay? And folks, I want to tell you, if a doctor does that, if he's saying, well, this is what we see so far, but we don't know about this, she is not hedging. Okay? She's telling you the truth. You know, if they say we don't have enough information yet, that means we don't have enough information yet. Something else might come in that will affect the situation. But for now, here is a snapshot of a moving process. Take a snapshot. You know, you see a runner running down, take a snapshot, you see the runner running. Okay, that's that moment in time. You don't know that 2 seconds later he stumbles or falls. You don't know. You just have what you have. But based on this snapshot, this is what we see. And this is what the doctor has to do now. In a lot of cases, they will be able to tell you, okay, you came to me because you noticed that you were having trouble swallowing. I recommended that we do an upper endoscopy. We did an upper endoscopy. I did not like what I saw when I got down there. Bottom of your esophagus, it was tight and narrow. I didn't like the way that the tissue looked, so I took biopsies of it. Now the biopsies are back. The biopsies do confirm the fact that it is malignant. Okay? This is something that the patient, this is something in their life that they are now going to have to deal with. All right? I mean, there's no words that you can use that are going to change that path report, that are going to change what those cells are. They are what they are. Okay? And we have to meet this now. Okay, I get it. What do we do next? Fine. But you have to be able to communicate that to people. Now, you could do it in a really cold way, you could do it in a threatening way, you know, or you could do it in a clear, straight way where the patient recognizes that you respect them enough to tell them the truth. You know, in a calm, clear way, without putting a lot of spin on it. Just give the information. Because there's going to be plenty of conversations after that about what we do next and here and what's involved and all these ins and outs, sure. But then the patient knows what's going on and can navigate and feel like okay, you know, this happened to me, but I'm still in control of my life, what I'm going to do, and I'm still making sense out of this, and I can process this and so on. Is this, am I clear about
yeah,
that?
Yeah, very much so.
So, the sugar coating and hedging, I know it goes on. I see it. I know it goes on. I disagree with that. I don't think that. I think that's disrespectful to people.
I personally would more appreciate a conversation like we're having now, with the facts as you see them. And you're the second doctor now that said snapshot. You know, the doctor last week.
I have not been it. Yeah.
Yeah. He said this is a snapshot at this point in time. This is what we see, and I would much more appreciate that type of.
Well, I think right. Of course, you know, I think we all would.
Yeah.
You know, I think we all would. We all I mean, it's just, I've already said it. I mean, it's just a question of respect.
Right.
You know, respecting the integrity of another person, the autonomy of another person, you know, the freedom of another person, and you know, people have to be free to think their own thoughts, process information the way they're going to do it. Absolutely.
Right.
So, people are not stupid. Okay,
Yeah.
people know the kind of relationship that they have with their doctor, and they can kind of tell. This person is leveling with me. This person is not leveling with me. This person cares about me. This person doesn't care about me. Just wants to get on to the next patient.
Yeah.
You know, people can tell that. All right. And what people, I think, in my view, what doctors should be doing, and I know that there is a tremendous imperative within the UH system along these lines. UH is really, really taking seriously the quality of the encounter that doctors have with their patients across the whole UH system. I mean, we hear about this on the inside. We hear about this all the time. You know, that this is a real priority for the organization, that people be respected, that people feel empowered, that people are comfortable, that they have confidence in the knowledge and skill of the doctor, and confidence in the relationship that they have with the doctor. Do you see what I mean?
Yeah.
They're two things, and you have to have both. UH recognizes this, and you know that's I have to say that's one reason why I feel very fortunate, you know, to have that logo.
Right.
Okay, I really believe that I am with an organization that is very serious about doing everything possible to do the right thing. So that's not true in all places, unfortunately, and everybody knows it. I'm not saying anything anybody doesn't know.
Right.
I just, you know, UH isn't perfect, but UH is working very hard, and UH actually does have this as its philosophy and is actually living it.
Yeah.
That's huge in this day and age.
Yeah. It is.
So I hope I've answered the question about communication with the doctor and getting news and the kind of relationships that should take place in and that sort of thing. And people can sit back and think about this and understand, hey, you know, I can insist on this kind of relationship. I want this kind of relationship. When I go to the doctor, I have every right to expect it. And if I don't have it, I can change that, or I can go somewhere else. Absolutely, you can. People are free.
Yeah. Very good.
Okay. Well, I think I've covered everything that Pat gave me when he gave me the questions. We started a month ago and did some, and we did the others now.
Right.
So I think that's probably it for this week.
That sounds great. Boy, it's been eye-opening. It's been more engaging sitting up here than behind the camera.
They ought to do this more often.
Well, I appreciate it.
All right. Well, I really appreciate you coming out and doing this one.
That's
It's
all
been
right.
good meeting you.
So
All right.
you're just a phone call away.
Yep.
599-7640.
That's right. Just give a call and tell Karen what you want us to cover, and she'll get the message to me, and we'll cover it.
Right. Plus, you're available for second opinions.
Oh, yeah, sure.
Anything medical-wise, you're available.
Any way I can help out, I'm happy to do it. People know that.
Yeah.
Glad to do it.
Yeah.
And we'll be back in a couple of weeks.
Right.
Not really sure what we're going to do. I may have another topic to cover with Pat. We do have some other guests coming up. We have a new ENT doctor, ear, nose, and throat doctor, who's with UH, going to have the office in Ashtabula. We'll be seeing patients from Conneaut and Geneva, well, our whole area. We'll probably be doing procedures in Geneva. But what that means is that our patients who have needed ENT care, and there have been plenty of them, now no longer have to go all the way to Concord. They'll be able to go to Ashtabula.
There's a grand opening for that office coming up soon, I believe.
That hasn't been communicated to me.
The what?
That has not been communicated to me. Doesn't mean it's not happening. It just means I don't know.
Because I heard about it, so something's coming up.
Oh, okay. Well, they'll get notice to me. I'm sure.
Yeah.
But that's Dr. Yilmaz, and he'll be joining us probably in September.
Yeah.
And then we're getting the last little details worked out with Dr. Mata. Dr. Mata is a pulmonologist and critical care doctor who is going to be very heavily in Conneaut, going to have an office in Conneaut. That's huge for us. He's going to be the guy who will manage the sleep apnea stuff. He's the guy who's going to be working with Dr. Argoti Green, who was on here, the thoracic surgeon, on the lung cancer stuff, finding it very early, curing it. So he's going to be starting up, and he'll be joining us. So we got a few shows lined up for folks.
Very good, Doctor. Thank you so much for tolerating me up here.
Oh, come on. This was fun.
All right.
Okay, folks. Well, thanks for tuning in. I hope this was some value to you, and we'll see you next time.